Good morning, good afternoon, wherever you are. I'll just give it a little bit of time to get the people come in, and then we get started with today's topic. So if you're watching this on replay, gotta just move forward until we get started with the presentation. Let's just give it a couple of more seconds until the people come in for today's topic, and then we want to get started. Let's just wait another second. Okay. Good morning, good afternoon, good evening, wherever you are. Thank you so much for coming on to today's YouTube live stream for Intensive Care Hotline and Intensive Care at Home. Thank you so much for coming on to the show. I'm your host, and my name is Patrick Hutzel, founder of Intensive Care Hotline and Intensive Care at Home. Today's topic is, I've been given a do not resuscitate order, but I want to live, and we will dive very deep into today's topic. But before we get into today's topic, I just want to do some housekeeping talk about some housekeeping stuff. If you have any questions regarding today's topic, please type them into the chat pad. You can also dial in live on the show. Please keep your questions initially on today's topic. We might have time to answer other questions later, depending on how long we'll need to go through today's topic. Now, what makes me qualified to talk about today's topic? In case you're wondering, I'm a critical care nurse by background. I have worked in intensive care for over 20 years in 3 different countries. I have worked as a nurse unit manager in intensive care for over 5 years. I have been consulting and advocating for families in intensive care for the last 10 years, and we're consulting and advocating for families all around the world every day, and have done so for the last 10 years. I'm also the founder and managing director of Intensive Care at Home, where we provide intensive care at home services for predominantly long-term intensive care patients requiring mechanical ventilation and tracheostomy. And we are currently operating all over Australia, and we're also now branching out into the United States. So that's a little bit about me. Today's topic was actually triggered by one of our clients who we worked with in the last few months. I don't want to mention his name, but you know who you are if you're watching this. But it's also been triggered by many conversations we've had over the years. It's also been triggered by my own experience working in ICU and talking to people in ICU all day, every day. And recently there was an article on the BBC website titled, I've been given a do not resuscitate order, but I want to live. And this is something, I've seen and experienced and worked with for the last 15, 20 years, where, people in ICU are issued with a DNR. They have not been asked whether they want it. They have not been consulted. Most of the time, it's quite frankly illegal, right? And ICUs or hospitals are simply doing it to manage their beds and override patients' wishes. But let me read out the article as a starting point today, and then we'll dive deeper into this topic. So this is an article from the BBC website from the 21st of January 2023. So it's not even 6 weeks old. And as I said, it's been forwarded to me from a client that we worked with, where in the UK, where this is exactly what happened. His mother had been issued with a DNR without her consent, without asking him, because he's the power of attorney, right? And he only found out because we asked him to ask that question, because we know this is happening all the time. And they only tell you if you ask them. I knew in my gut that they had issued a DNR, just the way they were presenting the case of his mother to him, the way they were offering or withholding treatment. I knew in my gut that they had issued a DNR without telling her and without telling him, which is illegal, and it's highly unethical. And it's really related to managing beds and resources in ICU. But let's read out the article. And it starts with a picture of the lady, and here the picture of the lady says, underneath the picture says, Mary McLean will not be given CPR. CPR stands for cardiopulmonary resuscitation, if her heart or breathing stops. Now let's get into the gist of the article. A Lancashire grandmother says she's living in fear after finding out doctors issued a do not resuscitate order without her knowledge. The document on Mary McLean's medical file instructs medics not to attempt CPR in the event of an emergency. Again, CPR stands for cardiopulmonary resuscitation, which basically means mechanical attempts, chest compressions to restart the heart in the event of a cardiac arrest. The 63-year-old from Airdrie says she now cannot sleep because she's afraid of not waking up. NHS Lancashire said its hospitals followed NHS Scotland guidance on do not resuscitate or DNR orders. Something is seriously wrong in Scotland, in the UK, in the NHS, if they are following NHS Scotland guidelines or NHS UK guidelines without talking to their patients and families. That's highly unethical. It's highly immoral and potentially illegal. But let's read on. The health board said any decisions should be discussed with the patient or carer by medical staff. Mrs. McLean was rushed to hospital almost 2 weeks ago when she was found to be unresponsive. Her daughter, Louise Gallagher, told BBC Scotland, "The consultant took me into the family room and explained we have put her on a ventilator. If this doesn't work, we also have to put a DNR in place. So we won't be resuscitating her should she flatline." What a terrible word to use, flatline. You know, that is an absolutely terrible word to use. So then it goes on. There were no discussions with anybody regarding the DNR. Let me repeat that. There were no discussions with anybody regarding the DNR. Can you imagine? So someone is just putting a DNR on someone's file without knowing the patient. What are their wishes? What are their values? What are their beliefs? Are they religious? Are they spiritual? It's just a complete walking all over people here. Mrs. Gallagher said medics did not ask whether she agreed with the DNR or whether it was what her mother would have wanted. So what happened to patients' and families' wishes? What happened to that? In 2023, we're just throwing this out of the window? Is that where we're at? Also, I have put a link to this article in this recording, or on the right-hand side. You can actually read the article if you want to. The article carries on. If they would have asked me, I would have said no, absolutely resuscitate her, bring her back. She has no illnesses. She is not in end-of-life care, not sick or poorly. On her medical records, it's just that she has asthma. They said she had a chest infection or pneumonia, and I wouldn't think it would warrant a DNR being put on her. Bear in mind, this lady is 63. She's not 93. She's 63. That's very young. The article carries on. We asked for a second opinion and did not get it. We asked to speak to the consultant when we were up in the critical care area, and we did say that we did not agree with it. So then the article carries on with a subheadline in bold: what is a do not resuscitate order? A DNR, a do not resuscitate order, also known as DNA CPR, do not attempt CPR, or a DNAR, which stands for do not attempt resuscitation, is a form filled in by a doctor or senior nurse which instructs medical staff not to perform cardiopulmonary resuscitation, also known as chest compressions, treatment to attempt to restart the heart and breathing after they have stopped. Other treatments will be used, but not CPR. The decision has to be taken because CPR, which can involve chest compressions or an electric shock, often does not work and very few people make a full recovery near the end of life. There may be no benefit in resuscitation. Now, I would change the wording here to there may be no perceived benefit in resuscitation, because at the end of the day, it's all perception. If someone perceives to be no benefit to resuscitation, other people may perceive benefit to resuscitation. But I'll come to that breakdown a bit later. In most cases, people should be informed when a DNR is in place, and medics should discuss it with the patient or next of kin, which is not what happened in this case, and which is not what always happens in most cases. But again, I can give more information after we've gone through the article. Official guidance states no doctor will refuse a patient's wish for CPR if there is a fair chance of success, but patients cannot demand treatment that will not work. Now, the first thing that I will say here is, for this particular lady here, well, she's on a ventilator, or she was on a ventilator in ICU. Well, of course, CPR should work, right? If this lady only has asthma, and the only reason she's on a ventilator is asthma, she should absolutely be given CPR, right? But I will talk more about the ins and outs a bit later. So then, in the article, there's another picture of Mrs. McLean and her daughter, Louise Gallagher. And underneath the picture, it says, Louise Gallagher, the daughter, was told by medical staff the order was already in place when she arrived at the hospital. Okay, the article continues. Mrs. McLean has now been discharged from hospital, but she fears becoming ill again. I'm not sleeping at night, she said. I am panicking in case I don't wake up. I can't get it out of my head. I've been in and out of the hospital with my chest, but the next time if I go in like that, or not even as serious as that, they may say, oh, well, she's got a DNR, just let her go. That's what's going through my head. And that's what should be going through her head. Here is the thing. What I've seen in intensive care and advocating for families in intensive care for a decade now. Once a patient has a DNR, ICUs will not give it their best shot. It's almost like they've written off a patient. It's almost like families or patients have agreed to, well, we don't need full treatment here. Let's just wind everything down and let just people die, or let them not go back into ICU in case they deteriorate and so forth. That's why we advise families in intensive care, and it doesn't matter which country, never to agree to a DNR, because it means the ICU won't be giving it their best to help you. The article carries on. I'm scared that because of the state of the health services and not having beds, give me a chance. I don't want to die. I've got grandkids. I want to live. Her daughter, Mrs. Gallagher, added, if the doctors don't think it's beneficial and won't save her life, then that's fine. If my mum didn't have any quality of life, we might be in agreement. But my mum wants to live, and there's no talk that she doesn't have any quality of life. Right? Why would you not attempt resuscitation if someone has quality of life and wants to live? The article continues, it's playing God with people's lives and it shouldn't be their decision. And I couldn't agree more with you. It should not be a doctor's or a senior nurse's decision. It's the individual's decision, right? I believe that the health system has a duty to help people according to their wishes, not according to perceived resources available, right? Because that's what it is. It's perceived resources available. It's probably resource mismanagement in many cases, right? Resource mismanagement of the healthcare system. It's treatment of healthcare staff as well, because they are leaving intensive care in droves from what we are seeing, because they've been mistreated there as well, especially during the pandemic. Okay, so the article continues with a subheadline, Shock, Anxiety and Fear. The article continues, Age Scotland says it has heard from people who are finding out, in quotes, almost by accident, that they have a DNR order without having a conversation about it. So here's the thing. When we work with clients one-on-one who have loved ones in intensive care, we usually ask them for medical records straight away. And then we often look at medical records and then we often find a DNR without having it discussed with the family. That's highly inappropriate. It's illegal. It's amoral. It's unethical. You can label it whatever you want, but that's what it is. The article continues. Adam Stakura, its head of policy and communications, said it was creating shock, anxiety and fear among those affected. It is something there's too much secrecy about, and the fact people are finding this out by accident means the process isn't working at all, he said. He wants to see more consistency in decision-making with patients, although ultimately the decisions rests with the clinician. You can speak to your doctor, but you don't have a right to say remove this, he said. But people should have a right to find out if there is one in their name, who made the decision and when, and be able to question that to better understand it. So basically what they're suggesting here is that the clinicians have the right to issue a DNR without having a second opinion, without questioning it anywhere. Where does that leave us? Where does that leave us? There's perception of conflict of interest. What if they don't like a person? What if they have a conflict with that person? They can just issue a DNR or instruct one of their colleagues to issue a DNR. The article continues with another bold subheadline, Compassion, Care and Tact. Judith Park, Director of Acute Services at NHS Lanarkshire, said all its hospitals followed NHS Scotland guidance. In terms of good practice, any decisions regarding the application of the policy should be discussed with the patient and or carer by medical staff, and this is documented in the patient record, she said. It's important to note that the policy guidance refers only to do not attempt cardiopulmonary resuscitation. The guidance is clear that patients will continue to be managed with whatever treatments that are appropriate for their health and comfort, irrespective of the DNR status. Now, I question this straight away, like I said earlier, that from my experience, that as soon as a patient has a DNR, they will not give it their best shot. It's almost like they've written off a patient. The article carries on. The Scottish Government said that its guidance was clear that healthcare professionals were expected to discuss treatment options openly and honestly with patients and families, which is clearly not the case, and I will give some examples there in a minute. A spokesperson said it is essential that the information that CPR cannot be offered is clearly and sensitively shared with patients unless it is judged that the conversation would cause physical or psychological harm. Well, the conversation often does cause psychological harm, which is clearly evident in this situation. I will give you other examples as well. The article continues. Where a patient lacks capacity to engage in this conversation, relatives or others close to the patient must be informed without delay where that is practicable and appropriate. CPR will not always be an effective or viable treatment option for everyone, and where clinicians determine that this is the case, conversations should always be handled with the utmost compassion, care, and tact. Well, from my experience, there is no passion, care, and tact, because most of the time it's not even communicated to patients and families. When a disagreement occurs, individuals can always request a second medical opinion. No one should ever feel pressured in any way when they are discussing treatment options such as CPR. Now, that concludes the article. I can tell you from experience, getting a second opinion, especially in the UK, is very difficult, because it's from my perspective, it's a socialist healthcare system, and the NHS is it's all about mates covering mates, and there's no independent third party, really doesn't really exist in the UK. It's different in America, different in Australia, but in the UK, from my experience, it's just non-existent. So that concludes the article. Let's underline, or let's sort of continue with some case studies where I can illustrate that what's being documented here is actually what's happening in reality. I mean, this is obviously BBC, a credible source there in the UK, but let's give some other examples. So we were working with a client not too long ago, would have been just before Christmas, in the UK, and his mum was in ICU for a good 4 to 6 weeks with pneumonia. She couldn't get off the ventilator, and they were basically saying, well, there's nothing they can do, and the only way to deal with this situation is that she should be extubated. She should have a one-way extubation, and she should be moved to palliative care, because that's quote unquote in her best interest, because she won't have any, what I refer to, perceived quality of life. Well, the ICU never told our client about the option of a tracheostomy, especially after about 4 weeks of mechanical ventilation in an induced coma. So we educated the client that a tracheostomy might be the next step. We were then helping the client to advocate for a tracheostomy. It went as far that client ended up making a complaint to the hospital CEO, and lo and behold, within less than a week, the client's mum had a tracheostomy. Again, it comes back to that the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's exactly what's happened there. Anyway, lo and behold, the lady had a tracheostomy, not without complications. They had to change it numerous times before it was working. About another 4 weeks later, she got weaned off the ventilator, and early January, she got decannulated and had the tracheostomy removed, and she's now slowly recovering. As we went along helping this client, I said to the client that you better find out if the doctors have documented a DNR without ever asking you, without ever asking your mum, and just putting it on file. And after much delay, the client got access to the medical records, and just as I predicted, the client had been issued with a DNR without ever discussing it with anyone. I'll leave the judgment up to you, what you think about that. I believe it's highly unethical. I believe it's highly immoral. And again, it's driven by resource constraints. It's driven by mismanagement of resources. It's driven by a lack of ICU beds, by a lack of ICU staff. Again, a lot of people in the system have left the system, especially since COVID, because they feel overworked, mistreated by the system, and it's a systemic issue. And not only staff, but also patients are paying the price, patients and families, because they're not getting the treatment they want, need, and deserve. Okay, so then another example was also about 18 months ago, nearly 18 months ago, would have been September 2021, when we worked with another client in the UK who was in ICU at that stage for about 6 weeks. And she was very young lady, 46 years of age, was in ICU with COVID pneumonia, and the ICU wanted to withdraw treatment. Kind of a similar situation where we educated the client's family that a tracheostomy is probably the next step. She would have been ventilated for about 4 to 6 weeks, and we educated the client that a tracheostomy is the right next step. Again, the ICU didn't want to do that, saying that this lady won't have any perceived quality of life, and that it's quote unquote in her best interest to die, because again, they perceived as her not having any quality of life. Anyway, again, we educated the family that a tracheostomy is the next step, and the lady had a tracheostomy with our advocacy, and now about 18-20 months later, she's at home on BiPAP, and she's very happy and very gracious to be alive. Right? Again, she's a very young lady, 48 years of age, and she's now got young grandkids, and she's happy to have her family around, and in no way, shape or form does she not have any quality of life. She's got a very supportive family, but it looks like the NHS is approaching it with a one size fits all. As soon as someone is at risk of occupying an ICU bed for longer periods of times, then they come in with the big guns, which is the DNR, or what we also see often is a one-way extubation. People leave ICU and they have no second chance to be returned to ICU. How is that for a first world country where resource constraints dominate who can live and who can die? Again, I leave that answer up to you in terms of what you think about this. Other examples from the UK in particular, but in other countries as well. We see it in America, we see it in Australia, where we see it in Canada, where patients get issued with a DNR without talking to families, or pressure is applied to patients and families to sign a DNR. Our recommendation is do not sign a DNR, and especially when it comes to issues such as do a tracheostomy, do no tracheostomy. On the other hand, there are services like intensive care at home. If your loved one is stuck in ICU long term with a tracheostomy but wants to live, is ventilated, long-term ventilated, you should contact us at intensive care at home, and we can help you with taking your loved one home, if that's what you want. And especially if you're in Australia, we're operating all over the country. You should absolutely contact us. We can help you with funding as well. Just go to intensivecareathome.com and contact us there. Let's go to other examples where DNRs have been issued without family consent. Some of you watching this might recall the Alfie Evans situation in Liverpool in the UK at Alder Children's Hospital a few years ago. Might have been 2016, 2017, maybe even 2018. I can't remember. I have to actually Google it when it exactly happened. Alfie Evans was an 18-year-old boy at Liverpool Alder Hospital, where the ICU withdrew treatment against family wishes, where the ICU and the NHS and probably the UK government even denied life-saving treatment, denied alternative treatment that was available for Alfie, either in Italy, Germany, or the US. And basically the UK government and the NHS denied an 18-month-old baby to have a second chance at life. You wonder why. Why couldn't the family fly their child out to another country and have another go at treatment? So now we've got the state involved in people's choices when it comes to their children. And, DNRs have been issued there for Alfie Evans at the time. The same happened with Charlie Gard about 12 months prior. I'm just looking it up. Alfie Evans passed away in April 2018, and 5 years ago now. And Charlie Gard would have been about 12 months prior to that. And there would have been other children in the UK, unfortunately, where similar situations happened, where treatment was withdrawn. DNRs have been issued for children, and they were denied potentially alternative and life-saving treatment overseas, even though the families had raised money. It's unbelievable, beyond any words, to say at the least. Right, I'll give you other examples here to illustrate the whole DNR issue. So we had clients here in Australia where similar issues happened, where clients had been issued with a DNR in ICUs. And we found out by reviewing medical records, and the families didn't know. They only found out because we told them about the bottlenecks. We told them about what is probably on file, and we told them how to look for it. And once we found the evidence that DNRs had been issued against family or patient consent, we asked, or we recommended for the clients to take it to court, and the court here in Australia revoked that decision because, again, it's illegal, and it bought the families more time, and those patients actually survived, and they're still alive to this day. So there's definitely leverage in there when you know what to do, when you know what questions to ask, when you've got the right clinical advocacy at hand. Also, here is another issue around DNR. So what ICUs often tell families in intensive care when it comes to issuing a DNR, or some ICUs also talk about an NFR, which stands for not for resuscitation. Those terms are used interchangeably, but it's the same meaning and the same outcome often. They often say, well, if we attempt resuscitation and chest compressions, you might crack some ribs, and we don't want patients to suffer. Now, here's my take on it. Will you crack some ribs when you attempt cardiac compressions and cardiopulmonary resuscitation? Yes, the risk is there. Can you save a life by doing so? Yes, you can. So you might save a life. You might have some cracked ribs. Now, treatment in ICU, unfortunately, is often it often means patients going through suffering, right? Now, do people want to live? My answer is yes. Are people resilient? My answer is yes. I've seen many patients in ICU incredibly resilient, and they came back to ICU, after a little while, just saying hi and saying, hey, thank you so much for putting me through this. I'm so grateful to be alive today. Now, yesterday, for example, yes, that ties right in. I don't know why I didn't think about it earlier. Yesterday, for example, I had a meeting with one of our previous clients. We had a client last year in January 2022 here in Melbourne, in Australia. The client was in a big ICU here in Melbourne. The client had a cardiac arrest and a TBI, traumatic brain injury. He fell off a scaffold at work, and he ended up in ICU after cardiac arrest and traumatic brain injury. In the early stages of his ICU admission, the ICU pushed the family to withdraw treatment, saying, again, he's got a severe traumatic brain injury, he had a cardiac arrest. If he survives this, he won't have any quality of life. And they were pushing, again, towards end of life pretty quickly, within only a few days after the accident. Family didn't know what to do, searched on the internet, found our website, intensivecarehotline.com, and reached out. And I said to the family that under no circumstances should they allow them to withdraw treatment, because A, it's only been a few days. B, if he can't come off the ventilator, there's always the option of a tracheostomy. And the family had no idea. what a tracheostomy is. For those of you watching my videos on a regular basis, you already know what a tracheostomy is. But again, biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Lo and behold, we asked the family to advocate for a tracheostomy. They asked us to go to the family meeting they had in the ICU. We asked the right questions, and a few days later, the ICU, the client had a tracheostomy, right? And a couple of weeks later, this gentleman, besides many ups and downs, despite having high intracranial pressures, despite having infections, despite having setbacks, despite having a craniectomy where parts of his skull were removed to manage the intracranial brain pressures, got off the ventilator, and a few weeks later, he had the tracheostomy removed. He went on to rehab, had a cranioplasty done, had the skull put back on his head, right? Had a few more setbacks, went back into hospital with infections again. But I couldn't believe early January this year, a year later, after the accident, my phone rings and this gentleman is on the phone and he says, "Hey, I'm such and such. My family reached out to you a year ago and you helped me save my life. And here I am 12 months later, I'm alive. And whilst I'm not back to where I was before the accident, I'm very grateful to be alive. And I think you and your people played a big part in this." And then I said to him, "Thank you so much for reaching out to me. That means the world to me and my team. And can we meet? Because I would really like to meet you." And yesterday, I had a meeting with this gentleman and his family. And it was just the most amazing thing to sit down with him over a cup of coffee and have a chat to him and to his family, and see that the work we are doing is very much worthwhile. It's so much worthwhile. And yeah, it's just been great. So do not give up. Question everything. You have to question everything. You are in a once in a lifetime situation when you have a loved one in intensive care, and you can't afford getting it wrong. Because if you give in, your loved one might pass away and you don't even know what's happening. And 12 months later, you will come to me and you will say, "Hey, have I done the right thing?" But then it's too late. Then it's too late. So I hope that illustrates, what's really happening in the environment. I'll give you another case study. So we've been working with a client in London in the UK, would have been last year, October, November time. Same situation, right? Gentleman, a 60-year-old gentleman, has been in ICU for about 3 or 4 months at the time. Ventilated, tracheostomy, many ups and downs. Client is more or less desperate to go home. Can't go home yet. And one of the first things that I asked the family is, please find out if your loved one is having a DNR. And lo and behold, again, patient had a DNR, family had no idea what was happening. Patient had no idea what was happening. The decision was just made over the patient's head, right? Again, I let you make the judgment if you think that's right, whether you think that's ethical, whether that's moral. I let you answer that question. If a patient like this, for example, was here in Australia, we could take that patient home with intensive care at home. If you have a loved one in intensive care for months on end, you should contact us at intensivecarehome.com. We can help you take your loved one home. Also, if you're in the US with a similar situation, you should contact us as well. We now have a clinical liaison nurse in the US where we can help you getting your loved one home and we have avenues now. Please contact us as well. Okay. If you have any questions about the whole DNR issue, please type them in the chat pad or call in live on the show. The numbers are in the chat pad. If not, I have more emails that I want to go through that came in this week. Want to answer some clients' questions from this week. I just got to scroll through my emails, and then I will go into some questions. But in the meantime, please type your questions into the chat pad or call in live, and then I will answer your questions. So, first question from this week was, hi Patrick, on December the 5th, my 86-year-old father had surgery to remove his kidneys due to surgery. The surgery went well. Cancer was localized and the doctors told us that he was 100% cancer-free. However, a few days later, he suffered a complication, a pneumonia. He was intubated and taken to ICU. He was intubated for almost a month. During this time, he developed ARDS. ARDS stands for acute respiratory distress syndrome, also known as lung failure. Eventually, they tried to wean him off the ventilator, but were unsuccessful. They performed a tracheostomy and transferred him to the step-down ICU. He has been there for almost a month and a half. They tried to wean him off the ventilator and a couple of times without any success. During the time in step-down ICU, he has developed 3 different infections and on antibiotics. They are pressuring us to transfer him to LTAC, but we are refusing to have him transferred because we feel that he will not receive the best care there. This has been a very difficult time for our family. My sister and I have practically been living at the hospital for over 2 months now, since our father cannot be left alone because of all the mistakes the nurses and the doctors were making. We ask ourselves if our father will ever be able to come off the ventilator and if we are making the right decisions to keeping him on it. One day the doctors are telling us that he's very strong despite his age and has a good chance of coming off the ventilator. And literally the next day they're telling us that they believe that his lung muscles are too weak to ever come off the ventilator. We don't know who or what to believe anymore or what to do. My question is, does my father have a chance of ever coming off the ventilator? If so, what should they be doing to try to wean him off the ventilator? Are there certain exercises, therapy that the respiratory therapist should be performing to help him, such as inspiratory therapy? His oxygen level is currently at 50% because he is fighting off an infection, but it was at 25% not too long ago. We are hoping he can get back to that number. His oxygen saturation level is 100%. Thank you so much, from Sylvia. Hey Sylvia, thank you so much for sharing that question, and thank you so much for asking that question. So, number one, do not give consent to sending him to LTAC. You have not talked about that. Your loved one has a PEG tube. The first thing that you need to put a stop here is do not give consent to a PEG tube. Once he has a PEG tube, they can send him out to LTAC. I presume you haven't done that, but that's number one. Do not give consent to a PEG tube. They will send him out to LTAC. And if he does go to LTAC, he'll probably bounce back into ICU anyway. So first advice here for all of our friends and families in the US, when you have a loved one in intensive care with a tracheostomy, ventilator, nasogastric tube, feeding tube in the nose, do not give consent to a PEG tube. If you do, they can send your loved one to LTAC. LTAC is the better version of a nursing home. So do not do that. Next. Breathing muscles are weak. Fair enough. Ask them to mobilize him. Ask them to mobilize him. Get him out of bed so he can do some breathing exercises. Once he starts sitting up, his breathing muscles will strengthen, right? And and then hopefully he can start breathing again. Now, unfortunately, you have not shared what ventilator settings he's in. You said his oxygen level is currently at 50%. It was down to 25%. But the biggest question here really is, what ventilator settings is he on? Is he in a controlled ventilation mode where the ventilator is doing most of the work, or is he in a pressure support or CPAP ventilation mode where, or a BiPAP ventilation mode where your father is doing most of the work, right? As far as you, quote unquote, living in the ICU is concerned, I can only imagine what that looks like for you and your family, because, you know, that's a terrible situation. Now, again, if you're watching this and you have a loved one in a similar situation in Australia, contact us at intensivecareathome.com, call us or email us to info@intensivecareathome.com, and we can help your father or any loved one, children as well, go home. Now, because Sylvia, you are in the US, you should contact us as well at intensivecareathome.com. We've got our clinical liaison nurse in the US that can help you, getting you on to the right providers over there. So contact us one way or another. Coming back to the weaning process though, again, mobilization is key, right? A good day and night rhythm is key. Getting him off the ventilator or breathing spontaneously during the day so he can sleep at night. Maybe he needs a rest overnight, go back into a controlled ventilation mode so he can get a rest overnight. But many patients in ICU, especially long-term patients, and I would consider your father is a long-term patient, you know, make sure he's exercising during the day. And exercise in ICU means he's sitting out of bed, he's doing physical therapy, physiotherapy, you know, so that he's tired at night and he can sleep at night. Okay. But mobilization is absolutely key. Now you're saying we don't know what to and whom to believe anymore or what to do. Now, here is the good news. The good news is your dad is alive. Okay, when there's life, there's hope. That's the good news. The bad news is in a situation like that, you will need to be patient. You got to look for the little wins. So what do I mean by that? I talk about mobilization, right? When they start mobilizing your dad, maybe today, he can sit on the edge of the bed for 5 minutes. Maybe tomorrow, he can sit on the edge of the bed for 10 minutes. Maybe the next day, he can sit on the edge of the bed for 15 minutes. The day after, maybe he can sit on the edge of the bed for 20 minutes. The day after, he might be able to sit on the edge of the bed for 25 minutes. The day after, he might be able to get in a chair and sit in the chair for 30 minutes. Recovery in ICU can take a long time. The ICU doesn't want to give you the time, right? But unfortunately, that's the reality. Recovery in ICU is like a marathon, not like a sprint. Okay? So you got to be patient here, right? And in the meantime, work on getting him home with the right support. Okay? Again, unfortunately, there are no quick fixes. You know, unfortunately, there are no quick fixes in a situation like that. But you got to keep working on it, and you can't lose trust and faith that your dad will recover, right? Or at least have quality of life that is acceptable for you and for him. You can't lose trust and faith in that. I hope that helps, Sylvia. Let's move on to our next question. Next question is from Kira. My loved one has been on the ventilator for 9 days due to a seizure. She's alert, moving ahead, writing coherent, and feels ready to remove it. However, the doctor is saying she fails the spontaneous breathing test. Can you offer help or advice, or how would we know if what they're saying is accurate? Great question. So, I have seen patients being awake and alert and yet not pass the spontaneous breathing trial. What it probably means is if she goes in a CPAP or pressure support ventilation mode, her tidal volumes might be too low, pressure support might be too high, her arterial blood gases are not good enough to get her off the ventilator. So that she's simply not ready. So how to deal with this? She might just need a few more days of ventilation, right? If she had seizures, she might be having anti-epileptic medications that also have a sedative effect. Maybe you can ask them to look at those medications. Maybe she's a little bit too sedated from the anti-epileptic drugs, and maybe they need to change some of that to get her more awake and stronger to breathe. Talking about strength of breathing keeps coming back to, once again, physical therapy, mobilization, breathing exercises, coughing exercises. Again, a good ICU should be able to mobilize your loved one, even on a breathing tube. They should be able to sit her up in a tilt table, in a recliner chair, and do the breathing exercises there. I believe it's not a case of not being able to do it. It's a case of doing it. Okay? And look, ask for those things, spontaneous breathing trials. What is she up to? What are arterial blood gases like? I would imagine her blood gases are not good enough. Her tidal volumes might be a little bit too low. Pressure support and PEEP might be still too high. And that's why she keeps failing the spontaneous breathing trials. Okay, we've got time for one more question. No, that's, hang on, got another question. Okay, my loved one is in intensive care for 2 days almost now. I was getting at readings at home in the 90s for 2 years after an episode of cardiac heart failure and a 2-week hospitalization, but she came home with no oxygen initially. Suddenly, the readings dropped into the 80s. We're talking about oxygen saturation here. And Monday morning in the 70s, I called an ambulance, and in emergency, she dropped to 47%. She is on BiPAP now and have dropped her down from 80% FiO2 to 40%. But when they tried to put her on oxygen with a bag, she failed. She's 94 years of age. Wow. Okay. That's good. Well, I'm glad to hear that your loved one is not intubated. So she's on BiPAP. So the question now is, what do you want? Do you want your loved one to be intubated? I don't think that's a good idea. It sounds like she was fine at home off BiPAP for quite some time, but now that she's on BiPAP, the question is, could you manage her at home? My answer to that is yes. Again, with intensive care at home, you can. That would be my answer here. Unless what you haven't shared is why is she dropping her oxygen saturation, right? Is she having pneumonia? What's the underlying issue here? Have they treated the pneumonia? Right? That's the question, really. If they treated the pneumonia, has it worked? Why is it not working potentially? Does she have asthma? Does she have COPD? You haven't shared any of that. Your answer here is, have they treated the underlying cause? If yes, it's not working, maybe it's now developed into a chronic condition, then maybe you should be looking at home care again. Check out intensivecareathome.com. I think that's about it for today. If there are any questions, please type them into the chat pad now before we wrap this up, or call in for another quick question if you have one. So let's wrap this up. So if there are no other questions. So thank you so much for watching. If you have a loved one in intensive care, go to intensivecarehotline.com and call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. Also, if you have a loved one in intensive care long term, especially with tracheostomy and ventilation, or if your loved one is stuck on a respiratory ward with a tracheostomy or ventilator, but also on BiPAP or on CPAP, you should contact us as well at intensivecareathome.com. We can now help clients in the US as well and in Australia. So contact us. Also, we provide home TPN. If you need home TPN, you can contact us as well. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day, and we answer all questions intensive care and intensive care at home related. If you need a medical record review, please contact us as well. We can help you with a medical record review in intensive care and after intensive care, but we strongly recommend to do the medical record review while your loved one is in intensive care. So we can give you that second opinion in real time. Now, subscribe to my YouTube channel for regular updates for families in intensive care. Share the video with your friends and families. Click the like button, give it a thumbs up, click the notification bell, and comment below what you want to see next, what questions and insights you have, whether you agree or disagree with the whole DNR issue. I'll be curious to see your comments. Thank you so much for watching. I'll do another YouTube live stream around the same time next week. If you have any topics you want me to discuss, just again send me an email to support@intensivecarehotline.com or just leave a comment here, and I can discuss any topics that are relevant for families in intensive care. Thanks for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I'll talk to you in a few days. Take care.